Good morning, ladies and gentlemen. That's a really first early morning session for a microwave ablation, 8 o'clock. But we are all prepared, and I will introduce my team. That's Dr. Panay.
Good morning.
She's a senior assistant, and she's the right hand of my chief 2 times per week. And I'm really glad that she's here to assist me. That's Carrie Netterman, that's technicians here with really great experience on ablations and techniques, and she's responsible also for our interventional ambulance. And my name is Katrin Eichler. I'm a senior radiologist, and the very important person is a patient. She's a 76 years old patient with an HCC at the left liver lobe in segment 3. You see here on the monitor on the MRI of the 29 December, and you see the last necrosis in segment 8 and 6. She has in 2014 an atypical resection of segment 7. And we did a follow-up every 3 months for the last 3 years, and we have no local tumor recurrence, but we have a new lesion, a really small new lesion on the left liver lobe. I will show you with a diameter of 13 millimeters here. You see that here? And the difficulty in this case is the localization of the lesion, because the patient refused the chemoembolisation to marker with lipidol. That's a pity. In this case, you see the first CAT scan here, and the first needle. We did a team timeout. That means identification of the patient. We checked the consent. We checked the needle. We checked the blood panels. And then we can start. We do that with an infiltration of local anesthesia. That means a 10 milliliter solution of 2% mepivacaine on this entry side of the antenna. A small cut of the skin. Kannst du mir einen Tupfer geben? Kannst du mir einen Tupfer geben? I asked the patient if she has pain. Haben Sie Schmerzen?
Nein.
Good. She said no. We
And before you
control
start
it.
with your needle placement, could you just give us a brief introduction and showing us the technical setup? Because I think from the audience, not everyone is doing it every day, so it would be probably also interesting for us.
Okay, we did a CAT scan before. You see that here to look after the veins and the portal vein. That's the only marker at that time. And now we do a single shot CT scans, only one image, to look if we are on the right side, if we have the right angel there. The patient achieved a single shot antibiotics before. We do that under local anesthesia and a moderate sedation with dipidolor in the infusion and diazepam from the hand. Now she's a little bit tired, but she's here, and we can ask her everything. We do that at the interventional CAT scan. That means that I have a joystick here, that I can change the windows, I can change the images, and can compare it with the MRI and the CAT scan during the procedure. That's very easy for me to do that.
So it looks like an angio suite, right? You have your monitor, right, and face.
Yes, it looks like. And on the other hand, you don't see that now. That's a monitoring that we control the heart rate and saturation of the oxygen. That's very important because you use the medicaments and we have no anesthesiologist behind. That means that we are responsible for the health of the patient during the procedure. Okay, now you see here on the right side, that's the next needle. Here's the portal vein, and here's the lesion. That means that we give local anesthesia once more here. a small cut of the skin. And now the needle. That's a needle of Covidian. It's called M-print. You see here the needle and the camera. Perhaps you can see that. These antennas are available in 3 lengths. That's a small one. It's 15 centimeter. A standard one was 20, and a long one was 30 centimeter. And it's an internal cooled needle. That means that you have a continuous perfusing in the with saline solution with a rate of 60 milliliter per minute, that you can avoid damage around. Here's the active zone. It's a green one. And now we can...
What size does the antenna have?
You can fix it here. That's 15 centimeters. Active zone 2 centimeters.
The diameter of the probe?
The diameter of the probe, I will show you there. Das ist zu fix hier. Then you can fix it here once more. Hältst du's? Hältst du's?
This is the moderator.
Und dieses. Ich sehe gar nichts.
So we are now seeing your
okay,
fluoro
now
mode.
You see
yes.
the needle. Yeah. No, that's not fluoro mode. That's a single scan.
So you preferring single scans instead of continuous fluoro? Okay.
Yeah. I prefer it in the liver. If you do that in the lung, I prefer the fluoro mode. Jetzt wird es einen Moment wehtun. Now it hurts a little bit. Ja? Okay. Now press the liver down a little bit. That's normal, and the left lobe. Now we are there. I think if you compare it, it's pressed now. We are at the right position, I think so.
Could probably the cameraman show us both images from the previous
Perhaps
MRI and the CT
the
next to
side.
each other? I think you have it on your screen, don't you?
Yes, I have it on a screen on the left side, the MRI on the right side in this case.
Okay.
Yeah.
Yes,
Perhaps
we have a good impression that you're in the right place. So the catheter tip, has this to go beyond the lesion? Or are you just with the catheter tip within the lesion?
Through the lesion.
Yeah?
I'm through the lesion, sozusagen. Through the lesion that you have the central one for the ablation zone.
Okay.
Now you have the risk is that the patient is breathing now, that the catheter is going out on the left level lobe. Therefore, you have to fix it with the hand too. And we will start it now with 60 watt to look if it is okay for the patient, or with 80 watt, it is okay for the patient with a pain. And then you go up to 100 watt. Alles in Ordnung bei Ihnen?
Bis jetzt, ja.
Good. Okay, you start some minutes. You see here, you go now up over 10 minutes. We start with 1 minute with 80 watt, and then we'll go up. Then we check it now with a CAT scan once more. Perfect. It's a good location now. She has no pain anymore. That's a really small lesion. That means that you need only 2-3 minutes with 100 watt. That's a 2450 megahertz generator from Covidian. And now you see the air around the lesion there. You see that on the monitor
Yes,
in the
yes, we can see
auditorium?
that, yeah.
Okay. Now okay, I think we only need 2 minutes. Wie bitte? Yes. Now she has a little bit pain. I think we need only 1 minute more. We check it with a CT.
So the air which we do see, is this a good indicator that the ablation is
Yes,
working?
It is. Yeah, stop. Pardon? Yes, it is a good indication. It is. Now we are too high, I think. We go upstairs to 80 watt, but it's a really small lesion. That means that you only need 2 minutes for it. And then we can stop. You have with a microwave, you have a direct heating. That means that it's much more better than if you compare with other energies like radio frequency or so on. We stop it now. We stop it. Last scan. We go upstairs, downstairs to look if you're right. Here's a good thing.
One question. What is the rationale behind it? The time you're applying, as well as the energy in terms of what? Is it rocket science behind that, or just experience?
Oh, that's both. It's experience and manufacturer specification that we know after 1 minute how long is the diameter of the ablative zone. We know that before from the manufacturer and from our experience. We know that.
So for small lesions, you now choose 1 minute of ablation?
Yes,
with 80 watt?
The whole time was now. That's 80 watt. We started with 80 watt was for 1 minute, and then 1.5 with 100, and 1 minute was 80. And that's enough. That's only a 30 millimeter lesion.
Okay.
We will do an MRI examination the next day for the next 24 hours, and then you see the necrosis in the MRI.
Am I right that you will not perform a control scan with contrast enhancement after the ablation directly?
You can do that, but why? What you have to know now is if there's a bleeding, if you have pneumothorax, so on.
But just to make sure that you have the.
Now you go out without a.
Just to make sure that you ablated everything.
You start again. Okay, then you started again at the whole time at the same session. No, if there's a tumor recurrence or if you have not ablated the whole lesion, then we will do that next week, but not today. But I'm sure that we are right at that position.
Your lesion was about, so from our estimate here from Leipzig, it was about 1 centimeter from the liver capsule. Is this okay for the ablation zone? How far could a lesion be approximate to the liver capsule that you can still do an ablation? Or is it
5
risky?
millimeter. No, it is, yes, sometimes it's risky, but it's really hard for the patient because they have a lot of pain there.
Okay, so it's more the pain
It's a
sensation.
good. Yes, it is.
Okay.
Okay, then we go outside.
Need a track? We should start.
Okay, you show us the track ablation procedure, or
Yes, that's right. Track ablation.
Can you tell us why you're doing track ablation? Mainly due to bleeding, risk of bleeding, or is there?
Yes, risk of bleeding and tumor seeding. That's it.
That was it. Okay.
can you shortly comment
You
on
see
this?
the,
How many watts did you apply?
No, we applied 80 watts for 1 minute, 1.5 minutes, 100. That's the maximum of this generator, and 1 minute with 80 watt.
And for the
That's
track
enough
ablation?
for this lesion. For track ablation, 20 seconds.
Okay,
80 watt. Okay.
thank you.
Yeah. Thank you very much.
Thank you, excellent.
Frankfurt. Yeah.
I
You're
have a
welcome.
question.
Oh, there's a question from
We
the
ask the
audience.
patient if everything all right.
There's a question
Alles
from
in
the
Ordnung?
audience.
Yeah, please
Professor
go
Eichler.
ahead.
Okay.
I'm from Leiden University Medical Center. I see it's a small superficial lesion. Do you sometimes, you mainly use ultrasound to locate this, to put in the needle?
You can do that, you're right. You can do that if it is a official lesion, but sometimes it's near the vein, near the portal vein, then it's not so easy to puncture it. But we know that as a gastroenterologist, puncture as with ultrasound. We have 3 CAT scans here. We do that on CAT scan, then we see the air around it. If you do that on ultrasound, you have after 10 seconds microbubbles around the whole needle, and you don't see the lesion anymore and the location. I think it's much more easier to do that under CAT scan guidance. But you can do that
Probably
under
you
ultrasound, you're
can
right.
summarize. I think localization is also quite well with ultrasound, especially for superficial lesions.
Yeah.
But then the local
Yeah.
control is much more difficult due to the artifacts
is.
from the air, right?
I think
And it's also a
during
question
the
of the
intervention,
center
it's much-
of your experience, I guess. I think you do most of your interventions with CT and MRI, and then it's always, I think, the best to stay with the modality where you're the most used to it, right?
So I think we have one
sure.
more.
We started with laser-induced therapy, but therefore you need 2 teams. That means that you have the puncture in the CAT scan and the treatment in the MRI. You need a lot of persons to do that. But in the laser-induced chemotherapy, you see the signal loss in the MRI. You can do that under MRI guidance too. That's much more easier. But under ultrasound, for us, it's not so easy to do that.
Okay, thank you.
Yeah, one last question. I mean, ablation time was quite short, 2.5 minutes altogether.
Yeah.
The whole procedure was now less than
Small
10
lesion.
minutes. So then you are able to do in an hour a few patients. I mean, it's quite quick. How it is comparable
No.
with with other ablation, with thermal ablation?
Oh, I think the same. The time using thing is to prepare the patient to go on the table, sterile covered, and so on. That's the same time if you do that on the microwave or radio frequency. But we know that with microwave, we have a direct heating, and that's much more better for HCC nodules because you have no damage surrounding tissue, the cirrhotic tissue, near the lesion. And that's much more better if you have a spherical ablation zone, a small one, and you can control it with
Well,
a
for the
microwave
classic
much more
radio
better.
frequency ablation, there is no more room nowadays. So microwave has completely replaced this. What is your comment on that? Yeah.
Yeah, but it's much more expensive. You have to know that. It's much more expensive at the radio frequency antennas and the generator.
Good to know. Thank you very much to Frankfurt.